Tendon transfer for radial nerve palsy. Hello everyone, I'm going to make this topic a little bit more easier to understand. Now talking about the historical background. So all these studies dates back to World War I and World War II when Robert Jones who gave the most famous Jones tendon transfer. Now only one of the component is only universally accepted today. That is the pronator teres transfer to the wrist extensor ECRB transfer. So this is how we are gaining the wrist extension. Now, the rest, there is a controversy how to regain finger extension and thumb extension today also. Now let us talk about the Star's contribution in 1922. The Jones has said that he is transferring FCR also and FCU also, and he was also transferring the pronator teres. Now, what does Starr said? Starr said in 1922 that why not instead of using FCU, he used FCR and palmaris longus. By this, he preserved the FCU function, which was further substantiated by the Zachary principle, who said, always leave at least one wrist flexor intact. Similarly, Gore and Swarup modification, they used both FCR and FCU, however, but they confirmed that if we preserve FCU, it gives a better function, as FCU is a maintain the ulnar stability of the wrist. Scuderi principle, they just refined the wrist, the thumb transfer technique, and they said a tendon transfer should ideally power one tendon only. Now this is the classical tendon transfers we talk about. Like we need tendon transfer to gain wrist extension, for finger extension and thumb extension. Now let's talk about the Boyce transfer in 1960. Boyce said that he was the one who recommended star FCR approach only. He said FCU transferring FCU is not an ideal option, and he gave the reasons for the same also. He said one, the FCU is a more important wrist flexor than a FCR. Why so? He said that the normal axis of wrist motion is from dorso-radial to volar ulnar. So that means the radial extensors and the ulnar flexors, they are more important. They create a balanced motion. So it is very important to preserve the ulnar flexors. Also, he used the argument given by Paul Brandt's biomechanical studies, which says that FCU should not be used because one, the FCU is too strong and its excursion is also too short for the transfer to gain the finger extension. So in order to gain the finger extension, the patient has to use the tenodesis effect as the excursion is very short. Second, it says that it is a primary ulnar stabilizer of the wrist, the FCU. So it is very important one to sacrifice. So despite this, all of these arguments, many studies have shown that even with FCU transfer, there is not much of functional loss of power grip. The third argument gave was excursion mismatch problem. He said the wrist flexors have an excursion of around 33 millimeter, while the finger extensors have an excursion of around 50 millimeter. Now what we are doing, we are transferring the wrist flexor to gain the wrist finger extensor to gain the extension of the finger. Now there is a mismatch of the excursion problem, so it will be only functional when the patient is going to use the tenodesis effect, then only it will be useful. So Boyce gave the argument. What argument he gave? Why are we using this wrist flexors? Why not we use just the FDS muscle? Because the FDS muscle have a larger excursion around 70 millimeters, so it is better suited for finger extension. So now what classical tendon transfers we read in case of a radial nerve palsy is number one, FCU transfer. In FCU transfer, the pronator teres is transferred to extensor carpi radialis brevis to gain the wrist extension. The FCU is transferred to EDC to gain the finger extension. The palmaris longus is transferred to the rerouted extensor pollicis longus to gain the thumb extension. Now what is the problem with this FCU transfer? The problem is as the FCR is preserved, so the patient will have radial deviation of the wrist. So FCU transfer is usually avoided in a case of pin palsy. Why so? Because in pin already the ECRL is also functional, and now you have kept the FCRL also preserved, so there will be strong radial deviation. So the second transfer is the superficialis transfer, which Boyce has recommended. The idea was instead of using the wrist flexor, let's use the FDS. So what did it says? One is the pronator teres to be transferred to extensor carpi radialis longus and brevis to gain the wrist extension. Then the FDS third tendon was used to transfer to EDC to gain the finger extension, while the fourth tendon was transferred to extensor pollicis longus and extensor indicis proprius to gain the thumb extension. And the FCR was transferred to gain to the abductor pollicis longus and also extensor pollicis brevis in Boyce transfer, which was later not used as it violates the principle of one tendon, one function. So in the later period, they are using only FCR to abductor pollicis longus. So the advantages is, one, it will have a large tendon excursion. Then you are not sacrificing the wrist flexors. Also for the thumb control, we have two different transfers, so it will be a better thumb control and also more independent finger control, because two different way we are transferring to the finger. One is separately for EIP and the other separately for other fingers. Now the third transfer, the brand transfer, the FCR based tendon transfer, where the pronator teres is transferred to extensor carpi radialis brevis to gain the wrist extension. The FCR is transferred to EDC to gain the finger extension, and the palmaris longus is transferred to the rerouted extensor pollicis longus to gain the thumb extension. We are using this word rerouted again and again. Why? Because if we transfer the extensor palmaris longus to the non-rerouted extensor pollicis longus, so EPL is present ulnar to the listus tubercle. So when we transferred it without rerouting it, so the pull will be only a dorsal pull. So the patient will only gain the extension. But if we reroute it outside the listus tubercle, so now the pull will be both abduction and extension. So the patient will have gained the thumb abduction along with extension. So all these three tendon transfers in multiple studies, they have shown that all of them have a similar functional outcome. So this is all. Thank you so much.